Hi everyone and welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Nagham Shabaka, your host for today's episode, and joining me today is none other than the OG Shabaka.
Hi everyone, this is Noha Shabaka. Welcome again. I was actually thinking about the pancreas. It's honestly crazy how powerful this organ is. When the pancreas is doing its job, you don't think about it at all. But once it starts acting up, it can cause anything from acute pain to long-term problems.
Before we jump in, let's talk about the normal basic structure of the pancreas. The pancreas is a complex lobulated organ with endocrine and exocrine parts. So it's like a two-in-one appliance. One side makes hormones and the other side makes digestive enzymes. And it's also retroperitoneal, meaning it lives kind of behind the peritoneum, like it's hiding.
Exactly, and that hiding spot matters clinically because many pancreatic diseases, unfortunately including cancer, can go undiagnosed for a long time, simply because it's tucked away in the back. Many pancreatic tumors remain hidden for so long. They have poor prognosis, so you often need a high degree of suspicion to catch pancreatic diseases.
Okay, now let's imagine this. A patient walks in, let's call him Ammu Mamdouh. He's 52 years old, wearing a galabeya that has seen better days. And he's clutching his stomach like it's a bag of gold he's trying to hide from his in-laws. He has intense upper abdominal pain that radiates straight to the back. He looks miserable, he is guarding, basically doubled over in the accordion position.
That doesn't sound very good.
But Ammu Mamdouh didn't just have a tummy ache. He attended a wedding last night and decided that the all-you-can-eat buffet was a personal challenge. We're talking 3 plates of kushari, extra mahshi, and enough kunafa to sink a cargo ship. When you ask him what happened, he insists it's the evil eye from his cousins, but his blood tests say otherwise. You check his labs, and the enzymes are up. His lipase and amylase levels are basically trying to exit through the roof of the hospital. You look at his abdomen and you see red semicircles around the umbilicus. You're thinking, this is not a tummy ache, and it's definitely not the evil eye. This is a full-blown attack of acute pancreatitis.
You might be wondering, why does pancreatic pain always sound like it's trying to stab the spine? Well, it's because anatomically it's deep and posterior. It is called the cardinal feature, often radiating to the upper back, and severe cases can look like an acute abdomen. So, in a scenario with severe acute epigastric pain radiating to the back, the examiner wants you to think pancreas. واضحة وضوح الشمس.
Oh, that clicks. That kind of pain pattern is a huge red flag for pancreas. Before we talk about diseases, let's quickly ground ourselves in what the pancreas actually does. One of its main jobs is making digestive enzymes. These are powerful chemicals that help break down fats, proteins, and carbohydrates once they reach the intestines.
So these aren't gentle enzymes, they're the heavy duty kind. And because they're so strong, the pancreas is very careful. It produces these enzymes in an inactive form and stores them safely until they're released into the small intestine, where they're supposed to work.
Okay, that already sounds like a safety system. And here's where the analogy helps. Think of the pancreas like a blender that stays unplugged until you actually need it. As long as it stays off, everything's fine. But if that blender suddenly turns on inside the box, that's a disaster.
And that blender turning on inside the box is basically what pancreatitis is.
Precisely. It's when digestive enzymes become active inside the pancreas, leading to self-digestion and inflammation.
Okay, so now it makes sense to talk about things that can mess with that system, like congenital anomalies.
Right, some people are born with structural differences in the pancreas that makes enzyme drainage less efficient, and that increases the risk of inflammation later on. First, there is pancreatic agenesis, which is very rare and involves partial or complete absence of pancreatic tissue. Rare, but definitely serious.
Then comes the most important one to remember, pancreatic divism. This is the most common clinically significant congenital anomaly of the pancreas. During development, the ventral and the dorsal pancreatic ducts fail to fuse. That leads to poor drainage, increased ductal pressure, and a higher risk of chronic pancreatitis. So it's like two kubri that were supposed to merge, but they never do. Traffic backs up, pressure builds, and everything gets irritated.
Perfect way to picture it. Next is annular pancreas, where pancreatic tissue forms a ring around the duodenum, potentially causing bowel obstruction, leading to symptoms like gastric distension and vomiting. The pancreas basically puts the duodenum in a chokehold.
Then there is ectopic pancreas, which means pancreatic tissue ends up in the wrong places. This happens in about 2% of people and most commonly found in the stomach, followed by duodenum and then jejunum. Same tissue, wrong neighborhood.
And finally, congenital pancreatic cysts, which are usually unilocular and can range from microscopic to about 5 centimeters. Okay, quick check before we move on. If you had to pick just one, which congenital anomaly is the most common clinically significant one? And why do we care?
Pancreatic divism. It matters because the ducts don't fuse properly, drainage is poor, pressure builds up, and that increases the risk of chronic pancreatitis.
Perfect. Now we move on. Back to our opening case. Acute pancreatitis is described as reversible inflammatory disorder. Severity ranges from focal edema and fat necrosis to widespread hemorrhagic necrosis.
Reversible is the key word. It's like the pancreas can bounce back if you remove that trigger.
Exactly. In acute pancreatitis, function can return to normal if the underlying cause is removed. That's only for acute though. Chronic pancreatitis is irreversible destruction of exocrine tissue.
And how common is acute pancreatitis?
The studies give an annual incidence around 10 to 20 per 100,000 in Western world. And here's a super high yield stat. About 80% of cases come from biliary tract disease or alcoholism. Also, about 5% of people with gallstones develop acute pancreatitis.
I see you started mentioning the causes and triggers of pancreatitis already, and guess what? There is a very popular mnemonic that everyone uses to remember the causes.
Oh, you mean I get smashed?
Yes. I for idiopathic, G for gallstones, E for ethanol or alcohol, T for trauma, S for scorpion stings, M for mumps or other infections, A for autoimmune, second S for steroids, H for hypertriglyceridemia and hypercalcemia, second E for ERCP, and D for drugs like cocaine, valproic acid, azathioprine, tetracyclines, as well as diuretics like furosemide and thiazide diuretics because they increase calcium reabsorption from kidneys. And remember, we said that hypercalcemia can trigger acute pancreatitis.
And as I mentioned earlier when we discussed epidemiology, the two main villains are alcohol and gallstones. That means we should always ask about them as part of history when we suspect acute pancreatitis. And if it's a kid, ask about trauma, as it's the most common cause of acute pancreatitis in children.
Yes, you're absolutely right. So when someone asks you about the most common cause of acute pancreatitis in adults, what will you answer?
Easy. It's gallstones first and alcohol second.
Good job. What about the most common cause of acute pancreatitis in children?
It has to be trauma, and we need to keep viral infections in mind too.
Okay, tricky question. What will be the most common cause of chronic pancreatitis in adults?
That's not a tricky question. For chronic pancreatitis, it's chronic alcohol use. But wait, what's alcohol doing to the pancreas exactly?
Glad you asked. When ethanol enters the system, it essentially creates a high pressure within your digestive plumbing. First, it causes the sphincter of Oddi to spasm and constrict, effectively slamming the door shut. Simultaneously, ethanol triggers the small intestine to release hormones that signals the exocrine pancreas to go into overdrive, pumping out a heavy load of digestive enzymes. Because the exit is blocked by the muscular spasm, these potent enzymes back up into the pancreatic ducts where they prematurely activate and begin to auto-digest the pancreas itself. This combination of increased pressure and internal chemical activation is the primary mechanical trigger for alcohol-induced pancreatitis.
Okay, sounds very intimidating. Let's recap. Simply think of sphincter of Oddi as a small valve where the pancreatic duct and bile duct empty into the duodenum. If the valve spasms or becomes swollen, the pancreatic juices can't flow out properly. Pressure builds up, enzymes get activated in wrong places, and that's when the pancreas starts to get inflamed.
Now, the big one, gallstones. Picture the pancreatic duct like a highway tunnel. Now imagine a truck, your gallstone, getting stuck in the middle. Pancreatic juice can't escape, pressure builds up inside the gland, and eventually the pipes leak. The enzymes activate too early and start digesting the pancreas.
Other causes include duct obstruction from things like neoplasms or parasites.
Going back to gallstones, how do you usually remove a stone stuck in the common bile duct?
Endoscopic retrograde cholangiopancreatography, or ERCP for short.
Yes, but ironically لو ربنا سترها and the stone in the common bile duct didn't cause acute pancreatitis by itself, you might induce acute pancreatitis while removing the stone using the ERCP.
Wow, that's crazy. So the gallstone can cause acute pancreatitis, and even in the case that it doesn't, you may cause acute pancreatitis by trying to remove the stone using ERCP.
There is no escaping it.
There's this entity called hereditary pancreatitis, which causes chronic pancreatitis. In this case, the issue isn't the pipes, it's the enzymes themselves.
So, pancreatitis that is genetic basically.
Yes, there are two main genetic mechanisms. One involves a mutation in the PRSS1 gene, which causes trypsinogen hyperactivation that leads to autodigestion. The other involves loss of function of SPINK1, affecting the trypsin inhibitor. When that protection is lost, the pancreas becomes more prone to self-digestion.
So it comes back to the same idea. Enzyme switching on too early, like the blender turning on inside the box. Here is a mnemonic. Press desync. Press, which is the PRSS1, think of a pressure valve that is stuck on. This mutation causes trypsinogen to hyperactivate, turning into trypsin prematurely, putting pressure on the pancreas by starting the digestion process too early. Sink, which is PINK1. Think of a kitchen sink or a safety sink, meant to catch and neutralize overflow. This gene normally produces a trypsin inhibitor, the drain plug. If you lose the sink function, you lose your protection and the pancreas sinks into a state of self-digestion.
Another cause of chronic pancreatitis is cystic fibrosis. The scenario usually includes chronic cough, lung infection, infertility, steatorrhea, malnutrition, and salty sweat. But how is this related to pancreatitis?
That's a very high-yield concept. Most people think about lungs when they imagine a child with cystic fibrosis. How does it affect the pancreas, you may ask? Imagine the pancreas as a juice factory with pipes carrying digestive fluid to the intestine. Now imagine those pipes are supposed to carry thin, watery juice. But in cystic fibrosis, the fluid becomes thick and sticky, like syrup instead of water. The CFTR gene normally controls chloride and water movement. When it's defective, less water enters the duct, so the pancreatic juice becomes thick.
Yes, and that thick juice clogs the small ducts and the cascade begins. This eventually results in damage of the pancreas, as it is a chronic situation, impairing the pancreatic exocrine function, which is needed to digest macronutrients including fat, resulting in fat malabsorption that manifests as steatorrhea, foul-smelling stool, malnutrition, and fat-soluble vitamin deficiency. Okay, that was a lot of causes. Alcohol, gallstones, genetics, cystic fibrosis. I feel like Amma Mdouh would be so confused at this point.
Don't worry, let's make it simple and group everything into causes of acute pancreatitis and causes of chronic pancreatitis. For acute pancreatitis, think about the I get smashed mnemonic we mentioned earlier.
So if it's an acute attack, we think about stones, alcohol, trauma, metabolic causes, or drugs.
Exactly. Acute causes are usually sudden triggers that activate pancreatic enzymes prematurely and they're reversible. Chronic pancreatitis is different. It's about long-standing damage and fibrosis of the pancreas. The major causes include chronic alcohol use, which is the most common cause in adults, and it leads to repeated inflammation and progressive destruction. Hereditary pancreatitis due to genetic mutations like PRSS1 and SPINK1. Cystic fibrosis, where we have thick, sticky secretions that clog the pancreatic ducts, and other causes include autoimmune pancreatitis and chronic duct obstruction by tumors or strictures.
Okay, now that we've covered all possible causes, let's focus on clinical presentation, diagnosis, complication, and management. Basically, the full don't miss this up package.
And because pancreatitis questions are never just name the cause, they want the whole story: presentation, diagnosis, complications, and management.
Okay, let's start with the clinical presentation of acute pancreatitis. And back to Ammu Mamdouh. What are the classic symptoms that scream acute pancreatitis?
The headline is Sudden Severe Epigastric Pain Radiating to the Back. Patients often say it's going through me, and they look toxic and miserable.
Common associated symptoms include nausea and vomiting, anorexia, pain that gets worse after meals, especially fatty meals, sometimes relieved by leaning forward, and occasionally fever due to inflammation.
On physical examination, you find epigastric tenderness, guarding, which is a sign of peritonitis, decreased bowel sounds, also known as ileus, and finally tachycardia and hypotension, if there is severe dehydration or third spacing.
And the scary skin signs?
They're rare but very high yield. First, we have colon sign, which is very umbilical ecchymosis.
It looks like a reddish or bluish C-shaped discoloration around the umbilicus.
Then we have the Gray Turner sign, which is flank ecchymosis or discoloration on the flanks. And finally, Fox's sign, which is ecchymosis over the inguinal ligament.
These all suggest hemorrhagic pancreatitis seen in severe disease. So, if I see epigastric pain radiating to the back, vomiting, and high lipase, this means pancreatitis until proven otherwise.
Yes, exactly.
Noha, how do we make the final diagnosis?
You diagnose acute pancreatitis if you have 2 out of 3 criteria. 1 is the typical abdominal pain, which is epigastric and radiates to the back. 2 is an elevation of lipase or amylase at least 3 times the upper limit of normal. And 3 is the radiological signs that are consistent with pancreatitis. These can be seen on CT or MRI or even ultrasound.
2 out of 3? So, if you have a patient with classic symptoms and a diagnostic elevation of pancreatic enzymes, you do not need to do imaging to confirm. You've already confirmed with those 2 findings, even without imaging.
Yup. Something you should keep in mind about pancreatic enzymes is that lipase is generally more specific and stays elevated longer than amylase.
Now, we've diagnosed acute pancreatitis. How do we decide the severity? Is it mild or ICU now?
Clinically, if you see hypotension, shock, confusion, respiratory distress, that means severe until proven otherwise.
Do we have some sort of criteria to classify severity?
Of course we do. We can use severity tools like BICEP score, Ranson criteria, APASH2, and a revised Atlanta classification. The C-reactive protein levels can also be used to predict the severity of the disease.
Let's focus on the BICEP score for a second. It stands for Bedside Index for Severity in Acute Pancreatitis. It is a simple and quick scoring system used within the first 24 hours to predict the risk of severe pancreatitis and risk of mortality. B stands for BUN. I is for impaired mental status. S is 2 or more systemic inflammatory syndrome criteria findings. A is age more than 60 years. And P is pleural effusion on imaging.
Another important criteria that likes to be asked about in exams is the Ranson criteria. Ranson criteria is a clinical scoring system used to assess the severity and prognosis of acute pancreatitis, especially alcohol-related pancreatitis. They're measured at admission and again 48 hours after admission. At admission, we look at 5 parameters: age, WBC count, blood glucose levels, AST levels, and LDH levels.
At 48 hours, we look at 6 other parameters, which include hematocrit drop, BUN increase, drop in serum calcium, drop in arterial oxygen pressure, increase in base deficit, and increased fluid sequestration. But wait, how is serum calcium low? And you mentioned that acute pancreatitis can be caused by hypercalcemia.
I'm glad you noticed this. It's due to a process called fat saponification, and it indicates severe pancreatitis. And pancreatic enzymes, especially lipase, are released into surrounding tissue. Lipase breaks down peripancreatic fat into free fatty acids. These free fatty acids bind with calcium in the bloodstream, forming insoluble calcium soaps. As calcium gets trapped in these deposits, serum calcium levels drop.
Thank you for clearing this up. We're done with clinical presentation, diagnostic criteria, and risk stratification. Now, what's next?
Do you want to know the complications that Ammu Mamdouh might suffer from?
More complications? As if the terrible abdominal pain wasn't enough. Poor Ammu Mamdouh.
Unfortunately, yes. Acute pancreatitis doesn't always stay confined to the pancreas. There is a ton of complications, and for the sake of simplicity, I like to divide them into systemic and local complications. Let's start with the systemic complications, also known as the systemic inflammatory response syndrome. And these usually happen early. When the pancreas becomes inflamed, it releases digestive enzymes and inflammatory mediators into the bloodstream. The body reacts as if there is a major infection, even when there isn't one. This widespread inflammatory response affects the blood vessels and multiple organs.
So it becomes a whole body issue, not just a pancreatic one.
Exactly, and this is what makes severe pancreatitis dangerous. First is the hypovolemic shock. Inflammation increases capillary permeability. Fluid leaks out of the bloodstream into retroperitoneum and surrounding tissues, a process called third spacing.
So the circulating blood volume drops?
Yes, the patient becomes dehydrated internally, blood pressure falls, and vital organs don't get enough perfusion.
Oh, that's why aggressive IV fluid resuscitation is the cornerstone of early treatment.
Second is acute respiratory distress syndrome, ARDS for short. Inflammatory mediators travel to the lung and damage the alveolar capillary membrane. This causes fluid to leak into the alveoli. The lungs become stiff and poorly ventilated, leading to severe hypoxia. Patients may develop rapid breathing known as tachypnea, low oxygen saturation, need for mechanical ventilation in severe cases. Third is the acute kidney injury. Because of low blood pressure and reduced perfusion, the kidneys may not receive enough blood flow.
So it's basically a pre-renal failure at first.
Yes, initially it's pre-renal, but if the shock persists, it can progress to acute tubular necrosis and intrinsic renal failure. Fourth is metabolic disturbances. One of the classic metabolic findings is the hypocalcemia.
From the fat saponification we talked about earlier?
Yes, and the severe hypocalcemia may cause muscle cramps, tetany, and cardiac arrhythmias. Another issue is the hyperglycemia. The inflamed pancreas can't regulate insulin properly, so blood glucose levels rise.
We can also see metabolic acidosis due to poor perfusion and tissue hypoxia, which leads to lactic acid accumulation.
Fifth is disseminated intravascular coagulation, or DIC for short. In severe systemic inflammation, the coagulation cascade becomes abnormally activated.
So the body starts clotting everywhere.
Yes, tiny clots form throughout the microcirculation, especially in organs like the kidneys, lungs, and brain. The platelets and clotting factors get consumed, and the patient becomes prone to bleeding. It can manifest as oozing from the IV sites, bruising, or bleeding, and organ dysfunction from microthrombi.
So it's both a clotting and bleeding disorder at the same time.
Yes, and it's a sign of severe disease and poor prognosis. Finally, in the systemic complications is the sepsis and multi-organ failure. If pancreatic necrosis becomes infected, bacteria can spread into the bloodstream.
And that leads to septic shock. This can progress to persistent hypotension, organ failure, and high mortality if not managed aggressively. That sounds like a chain reaction: pancreas, inflammation, shock, organ failure.
That's a perfect way to summarize severe systemic complications.
Okay, so those are the systemic ones. What about the local complications around the pancreas itself?
Great question. Local complications are problems that happen in or around the pancreas itself, and we usually divide them into early and late complications depending on when they appear. First is acute peripancreatic fluid collections. In the early phase, inflammation causes leakage of pancreatic enzymes and fluid into the surrounding tissues.
So, fluid just accumulates around the pancreas.
Exactly. These are called acute peripancreatic fluid collections. They occur within the first 4 days, don't have a defined wall, and they may resolve on their own. Second is pancreatic necrosis, also known as necrotizing pancreatitis. In more severe cases, the inflammation cuts off blood supply to parts of the pancreas, causing the tissue itself to die. It can be sterile necrosis, meaning no infection, or infected necrosis, which is much more dangerous as it can lead to sepsis and organ failure like we saw in the systemic complications. In that case, there is a need for drainage or surgery.
I remember we spoke about bleeding pancreas and the scary skin signs earlier. Is this a local complication too?
Yes, it's the scary hemorrhagic pancreatitis. The digestive enzymes released by the pancreas are very powerful and they can even start damaging nearby blood vessels.
So, that will cause internal bleeding?
Yes, and this may present as sudden drop in blood pressure, falling hemoglobin, and signs of internal bleeding including Collins and Gray Turner sign.
What about the big belly that Ammo Mamdouh has? Is it kirsch or another complication?
No, it's not Kirsch, despite the crazy amounts of koshari and mahshi Amma Mamdouh consumes. This is pancreatic ascites. It happens because the pancreas is leaking enzyme-rich fluid. That fluid can spread into the abdominal cavity.
So, the patient ends up with fluid in his abdomen?
That exactly is pancreatic ascites. It happens when pancreatic ducts are disrupted or enzyme-rich fluid leaks from the inflamed tissues. And if you analyze this fluid, it will be rich in amylase and protein. The last common early local complication is paralytic ileus.
That's when the intestines stop moving, right?
Yes, and that is due to the severe inflammation in the pancreas, causing irritation to nearby intestines and disrupts their normal motility. This leads to decreased or absent bowel sounds, abdominal distension, nausea and vomiting, and failure to pass stool or gas.
So the gut basically goes into silent mode.
That's a good way to put it. It's not a mechanical obstruction, just a functional shutdown due to inflammation.
That all was acute. What about the late local complications?
The most popular is pancreatic pseudocyst, and it is an exam favorite. After about 4 weeks, some fluid collections develop a fibrous wall around them. These are called pancreatic pseudocysts
Why pseudo?
because the wall is made of fibrous tissue, not a true epithelial lining like a real cyst. This may stay asymptomatic, cause pain or fullness, get infected, rupture, or compress on nearby organs.
Now, the world of necrosis. When areas of pancreatic necrosis become encapsulated by a fibrous wall after several weeks, usually about over 4 weeks, we call it world of necrosis. So, it's like a pseudocyst, but filled with dead tissue instead of just fluid.
Perfect comparison. These are more complex and often need interventional drainage if symptomatic or infected.
What would you call it if it gets infected?
It's called a pancreatic abscess. If bacteria infects a fluid collection or the necrotic tissue, it can form an abscess, which is basically a bucket of pus near the pancreas. And this usually presents with fever, persistent abdominal pain, and signs of sepsis. A pancreatic abscess typically requires drainage and antibiotics.
So, early complications are mostly inflammation, fluid collection, and tissue damage, while late ones are more organized collections and infections.
Exactly. And knowing the timing helps doctors decide whether to observe, drain, or operate.
Let me see if I got this right. Systemic complications happen early and affect the whole body, like shock, ARDS, kidney failure, DIC, and sepsis.
Perfect.
And local complications are divided into early and late. Early ones include fluid collection, necrosis, hemorrhage, ascites, and ileus. Late ones include pseudocyst, wall of necrosis, and pancreatic abscess.
That's a flawless summary.
Poor Am Mamdouh. This disease really doesn't go easy on him.
True, but the good news is that with early diagnosis, proper risk assessment, and aggressive supportive care, many patients recover without severe complications.
Okay, so once we suspect acute pancreatitis, what investigation should we order? And how do we actually manage the patient?
Great question. Management of acute pancreatitis is mostly supportive, especially in the early phase. There is no single magic drug that cures it. The goal is to support the patient while the pancreas heals.
So, what do we order first?
We divide investigations into labs and imaging. Laboratory tests help confirm the diagnosis, assess severity, and look for the cause. Main labs include serum lipase and serum amylase. Other supportive labs include CBC, urea and creatinine, electrolytes, liver function tests, calcium levels, blood glucose, and CRP at 48 hours for severity.
Rising BUN is a bad prognostic sign, right?
Indeed, It's one of the strongest lab predictors of mortality.
For the imaging, do we scan everyone?
No, first-line imaging is abdominal ultrasound to look for gallstones, especially in suspected biliary pancreatitis. CT scan is the gold standard. However, it's not done routinely at admission. It's indicated if the diagnosis is unclear, the patient worsens, no improvement after 48 to 72 hours, and it can be very helpful if complications are suspected.
All right, now to the important part. What do we actually do for عمو ممدوح?
Management follows a few major pillars. Aggressive fluid resuscitation is the cornerstone of early treatment. It is started early within the first 24 hours and is adjusted based on vital signs and urine output. Proper fluid resuscitation reduces SIRS, improves organ perfusion, and lowers risk of necrosis and organ failure.
عمو ممدوح is screaming in pain. Do you want to do anything about it?
Of course, acute pancreatitis is extremely painful, so adequate analgesia is essential. Opioids are commonly used and are given according to pain severity. Early nutrition is important for عمو ممدوح too.
I thought we used to keep them MPO for days.
That used to be the old approach. Newer guidelines recommend early feeding. For mild pancreatitis, start oral low-fat diet within 24 to 48 hours as tolerated. For severe pancreatitis, use enteral tube feeding and avoid total parenteral nutrition unless absolutely necessary.
Patients should be closely monitored for oxygen saturation, urine output, blood pressure, and signs of organ failure. Severe cases may require ICU admission and organ support. But do we give antibiotics?
No, routine prophylactic antibiotics are not recommended. They're only used if there is infected necrosis or another confirmed infection. And of course, we need to treat the underlying cause. So we don't just treat the inflammation, we also fix the trigger. If gallstones are the cause, do ERCP within 24 hours if there is cholangitis or obstruction, and perform cholecystectomy during the same admission to prevent recurrence. If it's alcohol-related, counseling and alcohol cessation is important. If it's due to hypertriglyceridemia, start insulin therapy or plasmapheresis in severe cases.
So, think of management as 5 main steps. First, fluids. Second, pain control. Third, monitoring and oxygen. Fourth, early enteral nutrition. And lastly, treat the underlying cause. I've had enough of that emergency situation. Let's shift to a more chronic and gradual form of pancreatitis, chronic pancreatitis. It is the no-going back version, a reversible destruction of exocrine pancreatic tissue. So, Noha, how does it usually present?
Most patients develop repeated attacks of acute pancreatitis. Some experience jaundice or vague indigestion. In some cases, it stays silent until complications like pancreatic insufficiency or diabetes appear, so the damage can build up quietly.
Flare-ups are often triggered by alcohol, overeating, or medication like opiates that increase duct pressure. It's usually tricky to diagnose it early. It requires strong clinical suspicion.
So chronic pancreatitis is like a pancreas stuck in a long, toxic relationship with inflammation.
That's painfully accurate.
There is a kind of chronic pancreatitis which is autoimmune pancreatitis, and this type is kind of scary because it can mimic cancer.
It's a type of IgG4-related disease that turns completely normal organs into stiff, fibrous wood. That's why it looks exactly like a scary pancreatic tumor on a scan. But it has a secret weakness. It melts away with steroids.
Yes, if you hear a pancreatic tumor that disappears with steroids, that's not really a tumor. This IgG4-related autoimmune pancreatitis usually shows up in 2 ways. Type 1 is lymphoplasmacytic sclerosing pancreatitis, which involves a swirling scar pattern backed with IgG4 positive cells. While type 2, known as idiopathic duct-centric pancreatitis, is a more localized attack on the ducts themselves.
So, lymphoplasmacytic sclerosing pancreatitis has a swirling scar, while idiopathic duct-centric pancreatitis is focused on the ducts.
Yes, the most important thing to remember about this IgG4-related autoimmune pancreatitis is that it's a rarely one-and-done issue. It's actually part of a larger, whole-wide disease where the immune system starts over-repairing and scarring organs wherever it goes.
The most common symptom is recurrent or persistent epigastric pain, similar to acute pancreatitis but more chronic and nagging. It may radiate to the back, worsen after meals, or be triggered by alcohol or fatty food. Over time, the pain may become constant or, in some patients, actually decrease once the pancreas is severely destroyed.
The pancreas normally produces enzymes to digest fats, proteins, and carbohydrates. In chronic pancreatitis, that function gradually declines, known as exocrine pancreatic insufficiency. This leads to steatorrhea, which is bulky, greasy, foul-smelling stools, weight loss, malnutrition, and fat-soluble vitamin deficiencies, which are vitamins A, D, E, and K.
When does steatorrhea usually appear?
Only after more than 90% of exocrine function is lost, so it's a late sign.
Eventually, the endocrine pancreas is also damaged, and the patient develops diabetes. But this is called pancreatogenic or type 3C diabetes, and it often occurs late in the disease.
One very important long-term complication is an increased risk of pancreatic adenocarcinoma, especially in patients with hereditary pancreatitis, long-standing chronic pancreatitis, and heavy smokers.
You mentioned earlier that it's tricky to diagnose. What do we rely on?
Imaging is key. Common findings are pancreatic calcifications, which is a classic sign, dilated or irregular pancreatic ducts, and atrophic pancreas. Best imaging tools are CT scan, MRI or MRCP, and endoscopic ultrasound for early disease.
So, how do we manage chronic pancreatitis?
Management focuses on symptom control and preventing complications. Main pillars include lifestyle modification, which include absolute alcohol cessation, smoking cessation, and small, low-fat meals. Pain control, pancreatic enzyme replacement therapy for steatorrhea and malabsorption, diabetes management, which often requires insulin, and endoscopic or surgical interventions for ductal obstruction, pseudocysts, and severe refractory pain.
Now, coming to the final segment of today's episode, pancreatic tumors. These can be cystic or solid. Some are completely benign, while others are unfortunately among the most aggressive cancers we see. And here's something reassuring. Only about 5 to 15% of pancreatic cysts are actually tumors.
That is slightly reassuring. Let's start with cystic tumors. First is serous cystadenoma. This one is always benign. It usually appears in older women, often in the body or the tail of the pancreas, and contains cuboidal cells surrounding small cysts, about 1 to 3 millimeter, containing clear, straw-colored fluid. Most serous cystadenomas carry somatic mutations of VHL tumor suppressor gene.
So, serous equals sweet, harmless cyst. Basically, I would think of a calm older lady, quite gentle and not causing any issues.
Moving on to mucinous cystic neoplasms. These are very different. They also occur mostly in women, usually in the body or the tail of the pancreas, but they produce thick mucin and have a real risk of progressing to invasive cancer. They are defined by a unique columnar mucus-secreting lining supported by a dense, cellular stoma that mimics ovarian tissue. These lesions are high stakes because they are pre-malignant. Up to 1/3 can be associated with invasive adenocarcinoma, driven by a genetic profile of KRAS, TB53, and RNF43 mutations. Because of this high progression risk, surgical resection is usually the standard of care.
So, serous is the sweet grandma, and mucinous is the mean one that looks calm but could actually be dangerous. So, we don't trust it.
Perfect way to remember it. Mucinous always deserves closer attention.
Major red flag. And then we have the malignant one, pancreatic carcinoma. This is the scary one.
Unfortunately, yes. It's one of the leading causes of cancer death, with survival rates under 5%. It usually affects patients over 60. But Nagham, what actually causes it at the cellular level is that it develops gradually through genetic mutations. It often starts with small, precursor lesions in pancreatic ducts and progresses to invasive cancer. Remember, 4 genes are most commonly affected by somatic mutations in this neoplasm. You can remember them by the mnemonic kill cancer signals today. So the genes are KRAS, CDKN2A or P16, SMAD4, and TP53.
Somatic and germline mutations, don't panic. Let me remind you. Think of it as the difference between a personal glitch and a family legacy. Somatic mutations are lifestyle or luck mutation. They happen in your body cells during your lifetime, usually from DNA errors or environmental stuff like UV rays. And they stay with you and only you. They are not passed down. Germline mutations, however, are built in because they exist in the sperm or egg. They become part of the blueprint for the entire next generation. If you have a germline mutation, it's in every cell of your body, from your toes to your brain.
And the 4 we just talked about are the somatic mutations. Okay, let's talk about risk factors. Risk increases with chronic pancreatitis, diabetes, and higher BMI. Smoking also doubles the risk. Lucky for you, if you are a coffee addict like Nagham, don't worry, there is no direct link to coffee or alcohol consumption. On the other hand, diets rich in fruits and fiber may be protective.
We probably have some genetic syndromes related to pancreatic cancer.
Yes, some syndromes make someone predisposed like Peutz-Jeghler's, familiar atypical multiple mole melanoma syndrome, and hereditary pancreatitis. Remember the PRSS and SPINK.
How do patients with pancreatic cancer present?
Pain is common but usually appears late. Tumors in pancreatic head can cause painless obstructive jaundice. Advanced disease can cause weight loss and fatigue. A major clinical clue to remember is new-onset diabetes in older adults, especially one who is very thin, not your usual diabetic and obese patient. Serum levels of carcinoembryonic and CA19-9 antigens are also elevated. And finally, another classic clue is Trozo syndrome. Can you tell us what Trozo syndrome is, Nagham?
It is also known as migratory thrombophlebitis, a medical sign where blood clots spontaneously appear in various veins across the body, then disappear and reappear somewhere else. The migratory part is like a game of medical whack-a-mole. You know, that game at the arcade where heads appear and you squash them and then other ones pop up. This is similar. You might have a painful red lump on your arm one week and then it pops up on your leg the next. What's scary about it is that it's often the very first sign of hidden cancer, most commonly pancreatic, gastric, or lung cancer. Okay, Noha, let's see if our audience have been paying attention. What are the 4 key genes linked to pancreatic carcinoma?
Oh, I remember them as kill cancer signals today. K for KRAS, C for CDKN2A, S for SMAD4, and T for TP53.
Okay, Noha, before we leave everyone with pancreatic trauma, let's recap this whole episode in a way that actually sticks.
Starting with the basics, the pancreas is the sneaky retroperitoneal organ with 2 jobs, endocrine hormones on one side and exocrine digestive enzymes on the other. And because it's hiding, pancreatic diseases can stay quiet for way too long.
Exactly. Then we built the core concept. Pancreatic enzymes are powerful, so they're supposed to stay inactive until they reach the intestines. If they activate early inside the pancreas, boom! That's pancreatitis, blender turning on inside the box.
And we said some people are born with anatomy that makes drainage messy, like pancreas divism, the big high-yield congenital anomaly. Ducts don't fuse, drainage is poor, pressure builds, and chronic pancreatitis risk goes up.
Then we jumped into acute pancreatitis, reversible inflammation ranging from mild edema to severe hemorrhagic necrosis. The classic presentation is severe epigastric pain radiating to the back, plus nausea, vomiting, and sometimes that leaning forward posture.
And the causes, the 2 main villains, gallstones and alcohol, together around 80%. Plus I get smashed mnemonic for the fall differential. And the pediatric clue, trauma is the most common cause in kids.
Diagnosis-wise, we said it's 2 out of 3. Typical pain, enzymes at least 3 times the upper limit, or imaging findings. And lipase is the more specific one and stays elevated for longer.
Then severity, because not every pancreatitis case is the same. If you see shock, confusion, or respiratory distress, assume severe. And we highlighted the BICEP score, BUN, impaired mental status, systemic inflammatory response syndrome, age over 60, and pleural effusion on imaging.
After that, we calm down a bit with chronic pancreatitis, the irreversible no-going back version. It can show up as recurrent pain, jaundice, vague indigestion, or stay silent until diabetes and pancreatic insufficiency appear.
And autoimmune pancreatitis, IgG4-related disease, which can look like cancer on scans. But the plot twist is, it improves dramatically with steroids. If a tumor melts with steroids, it wasn't really a tumor.
Finally, we discussed tumors. We reminded everyone not every pancreatic cyst is neoplastic. Only about 5 to 15% are. Serous cystadenoma is the sweet benign grandma cyst, affecting older women in the body or tail of pancreas, and the cyst has clear fluid.
This is in comparison to mucinous cystic neoplasm, still mostly women and pancreatic body or tail, but thick mucin and real malignant potential, so it may actually become cancerous. It's the calm-looking one you do not trust.
And then the scary boss level, pancreatic carcinoma, very lethal, often detected late with red flags like painless obstructive jaundice, weight loss, and new onset diabetes in older adults.
Plus, the gene mnemonic, kill cancer signals today, KRAS, CDKN2A or P16, SMAD4, and TP53. And don't forget Trousseau syndrome, migratory thrombophlebitis, those whack-a-mole clots that can hint a hidden cancer.
So, overall, pancreas problems can be subtle, but the clues are classic if you learn the patterns. Back radiating pain, painless jaundice, unexplained new diabetes, those should make your pancreas alarm go off.
I still can't get over the idea of the pancreas digesting itself.
I know, right? And honestly, it's kind of a reminder that sometimes damage doesn't come from the outside. The pancreas literally injures itself when things go wrong.
Which sounds oddly familiar.
Exactly, just like us. Stress, negative thoughts, bad habits. Sometimes we slowly eat ourselves up without realizing it.
So maybe the pancreas is teaching us something today.
Take care of problems early, medically and personally, before they start causing permanent damage.
I think that wraps up today's episode. Thank you for having me.
Thank you all for listening to this episode on PodBites. Until next time. And here's where the analogy. And here's where the and here's where the
Nagham. Analogy.
analogy. And here's where the
تعملي ايه؟ عيدي.
And here's where the
ايدي من الأول ايه ده؟
ليه؟
بايظة.
Late ones include Susu.
Susu.